part 3 of 4 on our chapter 28, still with the female reproductive system. In this video, we're going to look at the female sexual response, pregnancy, as well as childbirth. So when we look at the female sexual response, there are a number of phases that we're going to address, as well as we're going to compare and contrast the male and female responses. I'm going to start off with a picture here, which is also in your textbook, and we're going to go through the various stages so you guys can follow along, which are in here after all these slides, available after the picture, or it might be before the picture. I think I made a few changes prior to starting with this video. So don't forget, don't have your children around with these videos, please, when we're dealing with this reproductive system. Alright, so the female sexual response can be viewed in terms of the same 4 phases as the male sexual response: excitement, plateau, orgasm, and resolution. Okay, so when we look at the excitement stage, with excitement and plateau, those are going to precede the orgasm phase. So excitement is marked by myotonia. Now, myotonia is basically dealing with the hyper excitability in different type of the muscle fibers. So it's marked by myotonia, vasocongestion, as well as increase in heart rate and blood pressure, and of course increase in our respiration rate. This is excitement. Now, with vasocongestion, although having the same mechanisms in both sexes, it has different effects in females. Now, the labia minora become congested and often protrudes beyond the labia majora. And the labia majora becomes reddened and enlarged, and then it flattens and spreads away from the vaginal orifice. Now, the vaginal wall, it becomes purple due to the hyperemia. And of course, the serous fluid, that vaginal transitate, it seeps through the vaginal wall into the canal. Now, this fluid, it will moisten and it will lubricate the vestibular, along with the secretions of the vestibular glands. Now, the inner end of the vagina, it dilates and becomes cavernous, while the lower 2/3, it constricts to form a narrow passage called the orgasmic platform. Now, the narrower canal and the vaginal rugae, it enhances the stimulation for both of the partners. Right, well, not necessarily both of the partners, but both partners, both individuals. So let me take a look at the uterus here. Here is the uterus. This is the stimulated one or excited one, and here is an unexcited. You see the difference between the two? Now, in a standing position, this individual is laying down. In a standing position, it's a little bit more vertical. But when we look at the excited stage, you see that it'll be a little more horizontal. No, sorry. Yeah, this one will be more horizontal. I'm sorry, if the person was standing, and this picture in the excitement stage, it'll be more vertical. So here it will stand more erect during the excitement stage, and then the cervix, as you see here, cervix here in excitement is not that distended, but in here is actually withdrawn and comes slightly away from, or lengthened away from, the vagina. And that two things that occur, which would be the vagina, the uterus standing erect, and the cervix withdrawing away from the uterus, is called a tenting effect. Tenting. Now, although the vagina is the female copulatory organ, the clitoris is more comparable to the penis in structure physiology, and the importance at the focus of erotic stimulation. Now, it is a high concentration of sensory nerves. Now, we're looking at the clitoris now. Has the sensory nerves, which are relatively scanty within the vagina. Now, both the penis and the clitoris, being homologous structures, have a pair of corpora cavernosus with deep arteries and become engorged by the same mechanisms. So the glands and the shaft of the clitoris, it swells to about 2 times its unstimulated size. Now, because the clitoris cannot swing upward like the penis can, it tends to withdraw beneath the prepuce. Now, when there's thrusting of the penis in the vagina, it tugs on the labia minora and by extension stimulates the clitoris. Now, pressure between the pubic symphyses of the partners may also stimulate the clitoris. What happens with the breast now? The breast also become engorged and get swollen during this stage here, this excitement stage. And the nipples become erect, and their stimulation will enhance the sexual arousal. Now, when we look at now the plateau is very similar to that of the males, with the respiratory rate, the heart rate, and the blood pressure at a higher level, but for a very short period of time before orgasm. Now, when we look at orgasm in females and women's, it's an intense sensation accompanied by involuntary contractions. Now, the intense sensation, it will spread from the clitoris from the clitoris, which is out here, through the entire pelvic region, sometimes with pelvic throbbing and a spread of sense of warmth. Okay, now the orgasm plateau, it gives 3 to 5 more or stronger contractions about 0.8 seconds apart, while the cervix plunges spasmodically into the vagina. Now the uterus, it exhibits peristatic waves of contraction. The anus and the urethral sphincters, they will constrict. Let me see if I can get it here. Which is here. These sphincters, they're going to constrict. Now the paraurethral glands, which are homologous to the prostate, sometimes expels this fluid. This is called female ejaculation. It expels copious fluid, which is female ejaculation. Now we have tachycardia, which is increase in heart rate, hyperventilation, which will occur, and the breasts and the areolae, they become larger and engorged. Now, in many women, you have a reddish rash-like flat flush that appears on the lower abdomen, chest, the neck, as well as the face. Now, during resolution, physiology returns to normal. Now, the uterus is going to drop forward like it was here. Drop forward to its resting position. Orgasmic plateau, which starts to relax, and we have the inner end of the vagina returns more slowly to its normal distension. So you see here's the vagina here, and here it is. It has enlarged, and in the resolution stage, it will go back to its normal state. Okay, will slowly return to its normal state. Now the flushness will start to disappear. The flushness I talked about, which will be on the chest, on the neck, and on the face, that starts to disappear. And then the nipples and the areolae, they undergo this rapid, they go back to its normal size. Now, unlike men, women do not have a refractory period. and may quickly experience additional orgasms. Okay? So those are the phases. We have excitement, plateau, orgasm, and resolution. Okay? So here's all this information. I'm going to skip forward to the next section. Now we're going to look at pregnancy and childbirth. Look at the different hormones, what's happening through the different stages of pregnancy, and also with labor, mechanisms of contraction. Alright, so let me look at gestation. Gestation is another word for pregnancy. Lasts an average of 266 days from the day of conception to childbirth. Now, the gestational calendar is usually measured from the first day of the woman's last menstrual period. Thus, birth is predicted to occur 288 days or 40 weeks from that LMP, the last menstrual period. Now, during pregnancy, the duration of pregnancy, called its term, is commonly described in 3-month intervals considered our trimesters. Now, prenatal development. Let me see, make sure I don't skip ahead. Let me check. Yep, I'm on the right track. So, prenatal development. It involves all products of conception. Now, the embryo or the fetus, as well as the placenta and the membranes associated with it, are collectively called the conceptus. Okay, so during the first 2 weeks of the developing individual is considered to be a blastocyst. Now, the embryo from day 16 all the way through week 8, it's called an embryo. So from day 16 all the way through week 8 is considered to be an embryo. And then a fetus, the individual, is considered to be a fetus from the beginning of week 9 all the way till birth. Now, the fetus is attached, we already know, by an umbilical cord, correct, to a disc-shaped placenta on the uterine wall, the uterine wall. Now, what does the placenta provide? It provides the fetus nutrition, waste disposal, gets rid of waste, and it secretes hormones that will regulate the pregnancy, memory development, and of course with fetal development as well. Now, the first 6 weeks after birth, the infant is called a neonate. Just make sure you know what a neonate is. The fetus, the embryo, and the blastocysts. You will see these again. Now, hormones with the strongest influence on pregnancy are the estrogen, progesterone, human chorionic gonadotropin, and human chorionic somatomammotropin. Okay, so these are secreted primarily by the placenta, but the corpus lutein, lutein is an important source of these hormones in the first several weeks. Now, if the corpus lutein is removed before week 7, abortion almost always occurs. Now, the corpus lutein degenerates from week 7 to 17, and the placenta takes over its endocrine control, or its endocrine functions. So let's look at the first one here, our HCG. This HCG is in the urine and is the basis of pregnancy tests and can be detected with the home pregnancy kits as early as 8 to 9 days after conception. Now, its secretions will peak around weeks 10 and 12, and then it falls to a relatively low level. Now, like LH, it stimulates growth of the corpus luteum, which doubles in size. Now, without this, the corpus luteum would atrophy and the uterus would expel the conceptus. And what do we say the conceptus was? Basically, that is the individual within the the individual, the uterus or the fetus. All right, so when we look at estrogen secretion increases to about 30 times the usual amount by the end of gestation. Now, the corpus luteum is a source of estrogen for the first 12 weeks, after which it is secreted mainly by or from the placenta. The adrenal glands of the mother and the fetus secrete androgen, which the placenta converts and changes it to estrogen. Now, estriol, remember we talked about estriol and estrogen? Sorry, so I can get these out so I don't lose you guys. Oops. Okay, it's not working. See if I can minimize it for a second and get these out for you. Let's go back to the current slide. Sorry. Let's see if it'll work now. I'm sorry, you guys. Huh. Okay, maybe it doesn't want to work. Alright, here we go. Alright, so we talked about the corpus. We talked about how it's the main source of that estrogen for the very first 12 weeks, correct? After those 12 weeks, we have the placenta, which is the main source of that estrogen. Now, the adrenal glands of the mother and the fetus, which I said, are the ones that's going to secrete the androgens. Then these androgens sorry. The androgens are going to be converted to estrogen. Remember, we have a low amount of androgens, a high level of estrogens. These androgens are going to be converted to estrogen by the placenta. That's a P. By the placenta. Okay? Now, the estriol, which we talked about when we talked about estriol, E-S-T-R-I-O-L. The estriol is the most abundant estrogen of pregnancy. Remember, I mentioned that earlier. I mean, in the last video, but has a weak effect. The estradiol is least abundant, but accounts for most of the estrogenic effects. Now, estrogen, it stimulates tissue growth in the fetus and the mother. Growth to the fetus and the mother. Okay. Now it also makes the pubic symphysis more elastic and the sacroiliac joints more limber. So the pelvic is able to widen during the pregnancy period, and then the pelvic outlet, which is that the opening, will expand during pregnancy. So if you guys remember what the skeletal system looks like and look at the pelvic girdle, we have this, say that's the pelvic girdle here. May not be too, but you have the symphysis here, symphysis, then you have this opening here. This is the outlet. This outlet is going to increase with the help of the estrogen. Okay? Alright, let's get rid of all my scribbly scraps and move on to my progesterone. Now, a great deal of progesterone is secreted by the placenta as well as the corpus luteum. Progesterone and estrogen suppress pituitary secretions of the FSH and LH. Thereby, it's going to prevent more follicles from developing during pregnancy. This is the basis for contraceptive pills and implants. Now, progesterone also suppresses uterine contractions. It prevents menstruation, and it promotes the proliferation of the decidual cells of the endometrium, which feeds the blastocyte. Now, once estrogen has stimulated growth of the mammary ducts, progesterone stimulates the production of secreting of the circulatory development of the acini in the breast. Now, the amount of HCS secreted in pregnancy is sometimes that of all other hormones combined, but is not really understood too well. Now, the placenta begins secreting this HCS around that 5th week, around week 5, but its output is going to increase steadily from then on until its term. Now, HCS is sometimes called a human placenta lactogen, because in other mammals it causes mammary development and lactation, but however it doesn't even induce lactation in humans. But its effect seems similar to a growth hormone, but a lot weaker, and it also seems to reduce the female's insulin sensitivity and glucose. Alright, so also this the HCS, it promotes the release of these fatty acids. Let me see what's over here. Nope, I didn't put it on there. But it releases free fatty acids from the mother's adipose tissue for her cells, so it can be used in lieu of glucose, for glucose, okay? Alright, so many other hormones are going to induce additional bodily changes within the female's body changes throughout this pregnancy. Now, the pituitary gland, it grows about 50% larger during pregnancy, and then produces marked very high levels of thyrotropin, prolactin, and our HCTH. Now, the thyroid gland becomes 50% larger under the influence of my HCG, pituitary thyrotropin, my HCT from the placenta. Now, the parathyroid glands, they're also enlarged, and they're going to stimulate the osteoclast activity, so that the fetus is able to get more calcium. My HCTH, that stimulates the glucocorticoid secretion, which may mobilize the amino acids. My aldosterone, I'm going through all the hormones, aldosterone, they're going to increase with their secretion as well, and they promote fluid retention, increases the mother's blood volume. And then our relactin, it's secreted by the corpus luteum and the placenta, which are there to synergize progesterone and stimulating the division of these decidual cells, and promotes the growth of blood vessels in the uterus. So there's a lot going on during pregnancy. So many things are going on with pregnancy. Alright, so here's a graph showing what is occurring with hormones and the levels, what's happening with each week during the during the course of pregnancy. These are weeks after the last menstrual cycle. So this is all the way from week 4. Week 4, this is after ovulation. Week 4 to week 40, which is basically supposed to be the week of delivery. Some are early, some are late. But you're looking at the various hormones and how they increase and when they increase. You have my HCG, which starts off very abruptly with an abrupt increase. And finally, slowly by week 17, 18, 19, it has dropped tremendously, and it starts to level off from to say week 21, 22, slight increase to the delivery date. And you see that the estradiol and the progesterone, they have a gradual increase from ovulation all the way to about week 24, and then progesterone, estradiol, it increases a lot faster than the progesterone, but they still increase, okay, till that delivery date. Alright, what other changes are going to occur for the woman during pregnancy? There's a lot of other changes, not just with the hormones, but we have the digestive system. They go through motion sickness, as well as constipation and heartburn. So morning sickness, the cause of morning sickness, the physiological behavior of why they get harm, why they suffer from it, they say it's unknown. But what are some of the things that occur? They have nausea. Usually certain things that may trigger it. Certain things that may have eaten before, certain smells, such as certain foods, different aromas that may cause the female to actually suffer from nausea and vomiting. And usually rises from bed in the first 3 months of gestation, so within that first trimester. Now, constipation and heartburn is due to the reduced intestinal motility, as well as pressure on the stomach, causing reflux gastation. So when you look at the diagram on the right hand side, you see how the fetus is situated. This is a cross section. So you see this is the intestines. The intestines are not supposed to be this high. You have the diaphragm up here, you have the lungs, everything is being compacted and pushed aside just to hold this fetus. That's why you have constipation, because you cannot have proper flow of the food going through to pass through properly. The baby's normally supposed to pass through throughout the digestive tract. And of course, you get heartburn because everything is packed and compressing. That's the stomach here, causing a backlog, causing those sphincters to work irregularly. So when we look at the basal metabolic rate, that's going to rise about 15% in the second half of gestation. Now the appetite may be strongly stimulated, but only 300 extra kilocalories per day are needed even in the last trimester. So there's no need to sit there and say, oh, I'm going to eat for 2, because you're not really eating for 2. You're going to eat basically for 1 and a bit. So eating 2 or 3 servings of food just because you're pregnant is not benefiting you at the end of pregnancy. Alright. Now some women are going to overeat, like I said, and they're going to put on a lot of pounds. They're going to put on at least 75 extra pounds, which is not needed, compared to someone that's a little bit healthier, and all they're going to put on is maybe 25 pounds total overall, because you have the weight of the baby, maybe 6, 7, you may have a 10-pound baby, and then you have the fluid, the placenta. I mean, yeah, you are going to put on some weight, which is normal, but you don't want to put on an excess amount of weight, which leads to our nutrition. Maternal nutrition should emphasize quality and not quantity. It's very important to have a balanced diet. Now, during that last trimester, the fetus needs more nutrients than the female's digestive tract can absorb. So the placenta is going to store these nutrients early and then release them later. That's why it's very important during the first and second trimester to eat properly. That placenta is going to hold it until till later, because during that last trimester it can't do anything. The female digestive tract cannot absorb the amount of nutrition that the fetus is going to need. So the demand is especially high for the protein, the iron, and the calcium, and our phosphates. Now, pregnant women needs an extra 600 milligrams of iron for her own hemopoiesis, and of course 375 for the fetus. Some females will suffer from low iron levels, and the doctor, the OBGYN would advise the mother to consume liver, not raw, but cooked liver, which is the quickest way to get it as well. You know, you can get it from a lot of these food groups, or iron pills. Now, the con side to those iron pills is constipation. So it's very important to make sure you consume a lot of water while taking those iron pills. Now, supplemental vitamin K is often given late in pregnancy to promote prothumbian synthesis in the fetus, and it minimizes, and that's to make sure it minimizes the risk of neonatal hemorrhaging, especially in the brain. We don't want the infant to suffer from any type of hemorrhaging. Okay. All right, vitamin D. Why does a female need vitamin D? And that's to help to ensure we have adequate calcium that's being absorbed, because the fetus needs that calcium as well as you. Now, supplemental folic acid reduces the risk of neurological disorders such as spina bifida. Okay, but it's effective only if taken habitually prior to conception. So when they say make sure you eat properly, you have a balanced diet, you're consuming everything that you need, you have to make sure, because a lot of times you don't know when you are going to get pregnant, and if you're not eating properly, it can affect your child. Okay. Alright, so when we look at the circulatory system also, that does have some effects on the female. There's adjustments. The placenta, it requires approximately 625 milliliters of blood per minute from the mother. Now, the mother's blood volume is going to rise about 30% during pregnancy due to fluid retention and homeopoiesis. Now, the cardiac output, which is the amount of blood that's expelled over a certain amount of time, it rises about 30 to 40% above normal by week 27. You see, yep, here it is. By week 27, but it falls almost to normal in the last 8 weeks. Now, pressure on the pelvic blood vessels by the pregnancy uterus can result in hemorrhoids, varicose veins, and unfortunately, edema in the feet, that swelling in the feet filled with fluid. Now, over the course of the pregnancy, our respiratory rate, looking at the respiratory system now, respiratory rate, it remains constant, but the tidal volume and the minute ventilation, it increases about 40% for 2 reasons. The oxygen demand raises in proportion to the woman's increased metabolic rate and the increasing needs of the female. So basically, you're going to need more oxygen coming in. You have to inhale more. And this demand, it increases in proportion to what the mother needs and what the fetus needs. So more oxygen needs to come in for the mom as well, for the mother as well as for the fetus. Second reason, it will be the progesterone. It increases the sensitivity of the female's respiratory chemoreceptors to carbon dioxide. And the ventilation is adjusted to keep her arterial PCOH, which is our partial pressure carbon dioxide, lower than normal. So we want to make sure the carbon dioxide stays low. This promotes diffusion of the CO2 from the fetus bloodstream through the placenta and into the maternal blood. Now later in pregnancy, a woman may feel dyspnea, lightheaded, and make more conscious effects to breathe. Let's look at the urinary system. Now, I still have my diagram here. But now, with the urinary system, aldosterone and the steroids of the pregnancy promote water and salt retention. Right, so then we have this filtration rate. This filtration rate is going to increase by 50%, and the urine output is going to increase slightly. And that's just to make sure that to ensure that things are eliminated from both the female's body as well as from the waste, from the fetus. Now, as the pregnancy is going to continue, you're going to have the uterus compressing the bladder, which we see right here. Here's the bladder. It's pressing against that bladder, and of course, you're going to have frequent urination. It's going to be very uncomfortable to sit in various positions, and you might have a little bit of incontinence where you have a little bit of urination occurring without you even noticing. Okay, so you're unable to control your urine that's leaking. Alright, so let's look at the skin. The skin undergoes a tremendous amount of changes as well. So the skin is going to grow just to accommodate what's happening with the fetus inside. The fetus is growing, your skin has to expand to accommodate. So some females will, as well as the fetus, as well as the fat that is being deposited around the hips, the thighs, and as well as around the stomach. So some females are going to receive stretch marks, and that results from the tearing of the connective tissue of the dermis, and these are usually reddish, but they fade away after pregnancy. Some of them fade away, and some of them they stay around quite a bit. Alright, so you might see the slide slightly changed. I just added 2 pictures so you can actually see what I'm referring to during pregnancy, how you have these marks, these stretch marks here. Okay, and that's just due to the tearing of that connective tissue. And it's slightly reddish, and some individuals of a darker hue, it may be black or dark brown, but on a lighter hue it'll be red. Okay. Now the melanocyte activity increases some areas and darkens the areola and the linea alba. Okay. Now some women also occur a temporary blotchy darkening of the skin over the nose, the cheeks, and that's called the mask of pregnancy, which usually disappears after the pregnancy. Some people have like a little dark patch somewhere on their stomach, maybe on their neck, just a little darkening areas, and that will obviously disappear. Alright, so the uterus obviously undergoes growth and weight, right? So the uterus, it weighs approximately 50 grams when the woman is not pregnant, and 900 grams by the end of pregnancy. Now it eventually reaches almost to the xiphoid process, which is obviously, you guys remember, from the sternum. And here we have this table here that's going to show you exactly what happens with the sources of weight gain in a typical pregnancy. So let me look at this is in a healthy female, a healthy pregnant. See, as I say, no one that's overeating. This is healthy. So we have the fetus as approximately 7 pounds in weight. We have the placenta and fetal membranes and the amniotic fluid, which is 4 pounds. We look at blood and tissue fluid, 6 pounds. You have fat, 7 pounds. Uterus, 2 pounds. Breast, 2 pounds, which gives you a total of an healthy average of 24 pounds. So it's expected the female to put on some weight. And this is the distribution of how this weight gain is set up during pregnancy. So here you have the fetus. Here's another diagram just to show you how everything is set up. This is the fetus. You see the bladder. You see how it's been compressed by the head of the fetus. That's why you have that frequent urination. Here's your pubic symphysis, and then you have the outlet, which you cannot see. Look at your ovaries on either side. Here is the small intestines. You see why you're gonna have constipation? Your diaphragm is in here, which you don't see, but your diaphragm is up in here. You see the liver, the stomach, how it's squished. And you see how your lungs, everything is pushed upward to the sides and down, all to accommodate a fetus. And here's that xiphoid process that I was referring to, which is the third part of the sternum. Alright, so childbirth involves what? The expulsion of the fetus by the uterine and the abdominal contractions. Now, in the 7th month of gestation, the fetus normally turns into a down head vertex position, which is what we saw in the previous diagram here. Head down, vertex position. And most babies are born head first. Now, although a passive player on its own birth, the fetus may play some role by chemically stimulating labor contractions. Basically, when it's ready to come out, it will come out. It will start pushing and pushing and pushing against that cervix, ready to come out. Some will not. That's why you'll have induced labors. But on the most part, you'll have those that are very passive and want to get out. Now, over the course of gestation, the uterus exhibits relatively weak Braxton Hicks contractions. At term, these transform into more powerful labor contractions that mark the onset of given birth, which is called parturition. Now we have the progesterone. Talking about progesterone, and our estrogen, more specifically the estrol. The balance between the two may be one factor in this particular pattern that we have of increasing the contractions. Now the progesterone inhibits the uterine contractions, but its secretion, it levels off or it declines after 6 months, while the estradiol secretion, they continue to rise, continue to increase. The estradiol stimulates uterine contractions. Hope you remember what I just said. The estradiol stimulates uterine contractions. Now, as pregnancy nears that term when they're ready to deliver, the posterior pituitary gland was going to release more oxytocin, my OT. And the uterus develops more of these receptors to receive these O2s, my oxytocins. The oxytocin is going to promote labor in 2 ways. 1, it directly stimulates the muscles of the myometrium. It stimulates the fetal membranes to secrete the prostaglandins, which are synergists of these O2s, of my oxytocin, in producing the contractions. Now, if labor is prolonged, if the oxytocin or my I cannot get this one right. Prostaglandins are lacking. So if we don't have these two hormones, it will actually prolong the labor, and it may be induced. They may have to induce the labor. Now, the conceptus may produce chemical stimuli promoting its own birth. Now, the fetal cortisol secretion increases late pregnancy and may enhance estrogen secretion in the uterus. Now, the fetal pituitary gland also produces estrogen, which may stimulate fetal membranes to secrete this hormone here. Now, when the uterus starts to stretch, it also plays a role in initiating the labor. Now, stretching increases the contractility, and movements of this fetus in here produces the sort of a stretch that it stimulates this myometrium. Now, with this fetus in this particular position, this head down vertex position, it presses against the cervix, which we see here, which is especially sensitive to stretch. Now, labor contractions begin about 30 minutes apart. 30 minutes. Now, as labor progresses, it becomes about 1 to 3 minutes. Now, it's very important that they be intermittent. Now, each contraction, it reduces maternal blood flow to the placenta. So as long as we're having these contractions, there's less blood flow going to the placenta to supply the baby, the fetus, So the uterus must periodically relax to restore blood flow and oxygen to the fetus. So the more contractions, whenever there's contractions, there's less blood flow to the baby, to the fetus, So when it relaxes, you have blood flow to the baby. When it contracts, it's less. Okay. Now, contractions are strongest in the fundus of the body, of the uterus. No, the fundus and the body areas of the uterus, and then is weaker. You see right here, weaker in the cervix. So remember, I said this is the fundus, this is the body, this is the cervix. You have more contractions occurring in the fundus and in the body area, and it's very weak near the cervix. And this is where the fetus is pushing down. It's pushing down the baby towards the fetus. Now, according to the positive feedback theory of labor, contractions are induced by the stretching of the cervix. So here we have the cervix stretching. These trigger a reflex contraction of the uterine body that pushes the fetus downward and stretches the cervix even more. Syria. It's going to push the cervix down even more. Oh, sorry, it's going to stretch the cervix even more. So in addition, cervical stretching is going to induce the endocrine and the nervous system reflex through the spinal cord, the hypothalamus, and as well as the posterior pituitary gland. The pituitary gland is going to release what? The oxytocin, which in turn is going to stimulate and circulate the uterine muscle both directly and through the action of this hormone here. This is also a positive feedback cycle. We have the cervical stretching, oxytocin secretion, uterine contraction, which in turn gives us our cervical stretching. Now, as labor progresses, a woman feels a growing urge to what they call bear down. And that's due to that reflex arc from the uterus to the spinal cord and back to the skeletal muscles of the abdomen. Now the pain of the labor is due at first mainly to ischemia of the myometrium during each contraction. But later, the pain becomes stronger because of the stretching of the cervix, the vagina, and the perineum, and sometimes the tearing of the vaginal tissue. Now, of course, you're gonna if there's a problem there, the OB/GYN with the obstetrician will perform an episiotomy. Here's the word, episiotomy. That's just an incision in the uvula, so that you can widen up the surface, widen the vaginal orifices, so the fetus can come out, and that's to make sure there's no tearing. It's called an episiotomy. Pain. There is pain. The pain of human childbirth, compared to that of other mammals, is an evolutionary product of two factors: the usual large head of the human infant, and the narrowing of the pelvic outlet. So it has to do with the size of the child's head and brain, as well as the narrowing of this pelvic outlet. Alright, so labor occurs in 3 stages, and the duration of each tends to be longer in a woman giving birth to her very first child than in a person who has not given birth, who has had multiple births. So that's our primipara and our multipara. So primipara is one it's basically their first pregnancy, or first time given birth, not first pregnancy, because you can have a number of pregnancies but still have your first birth. But then this is person multipara is basically you've had a number of children, you've given birth a number of times. So we're dealing with dilation, expulsion, and placental stage. When we deal with our dilation stage, this is the very first stage and is the longest when we're dealing with someone that's had her very first child. But as little as a few minutes when dealing with someone that has had a number of births. Now it's marked by the dilation of the cervix. Here's the cervix. Here's the cervix. So here we have the dilation of the cervix. And of course the thinning of the cervix. So it deals with the dilation of the cervical canal as well as the thinning of the cervix. Effacement. Thinning of the cervix. Now the cervix reaches a maximum diameter of about 10 centimeters, which is basically dealing with the diameter of the baby's head. Now during dilation, the fetal membranes usually rupture and the amniotic fluid is discarded. So that's basically the breaking of the water. During late dilation, it reaches about 10 centimeters. Here we have it, about 10 centimeters. You see it's not that wide here. But, sorry. We have 10 centimeters worth. So you see it's able, the child's, the crown of the head is able to pass through, the head is able to pass through the cervix right here. And see our pubic symphysis, where it is, where it was supposed to be? Okay. Alright, so the second stage is our expulsion stage. This is the second stage, typically lasts about 30 to 60 minutes for someone with their first primipara, and very shorter in the multipara. Now, what happens during this stage? This is when the baby's head starts to crown. It starts to crown. We have the crowning of the child's head. So the child head will enter the vagina and last until the baby is entirely expelled out. And then we have the baby's head crowning when you have the top of the head that is very visible and causing the vulva, sorry, to stretch. Now, delivery of the head is the most difficult part, with the rest of the body being following much more easily. Because sometimes you may have the cord wrapped around the head. Plus, you want to make sure you don't fracture any bones, because everything is still soft and so tender. So you want to make sure that you hold the head properly while bringing out the child. Now episiotomy. Let's see if it's on this stage. No, okay. The episiotomy is usually done at this stage, which would be down here, where they would make a small incision at the bottom. So this is the stage where the OBGYN or the obstetrician will perform an episiotomy. You will see that again. What stage does an obstetrician perform an episiotomy? Is it the placenta stage, the dilation stage, or the expulsion stage? You will see that again. So hope you're making notes. Now, what happens after that? An attendant, which would be the nurse's, the OBGYN nurse, she will often use like a suction ball to remove any type of mucus from the baby's mouth. They may have to unravel the cord from the child's neck, and they will clear out the nose as well before it can be fully delivered. So while the body is still inside, they would actually start suctioning the nose and the mouth. Now, if there's other complications, they're going to have to remove the child quickly, then do the suctioning. It all depends on what complications, how healthy delivery is when they will actually do the suctioning. Okay. Now, when the child is they do it right there. Some they do take it out, but the majority of it's done here, where they suction and then remove. Okay, now when the baby is fully expelled, the attendant is going to drains the blood of the placenta vein into the baby, and then clamps the umbilical cord in 2 places, and then cuts between them. Now, in this last stage is with the placental stage. This is when the uterus continues to contract after the expulsion of the baby. Now, the placenta cannot contract itself. The uterus is contracting. So what it does, since this placenta cannot contract, it buckles away from the wall, from the uterine wall. Now, about 350 milliliters of blood is typically lost at this stage, but contractions by the myometrium compresses these blood vessels and prevent from excessive bleeding. Now, the placenta, which you see right here, the amnion, this is the amniotic fluid, the amnion and other fetal members are expelled by uterine contractions. So sometimes what they'll tell you to do is push one more time while the OBGYN, you see the clamp here, while the OBGYN pulls the placenta out. So the membranes, or the afterbirth, must be carefully inspected to be sure everything has been expelled. Otherwise, postpartum hemorrhaging can occur. So they have to inspect to make sure to make sure no pieces have been left back inside. Okay. I know they were back in the 1800s, 1700s. They were not aware of the proper procedures way back in prehistoric days, where they were not aware of what was supposed to be removed and how much. So we've had a lot of research. Unfortunately, a lot of individuals have passed away just after childbirth, not knowing what was supposed to be left or what's supposed to remain in there. They'll just pull it out, or at first they didn't even know it's supposed to come out. They'll just clamp it and leave it in there. And a lot of females have died because of that, just not knowledgeable. So we have progressed over the years. So if there is if the blood vessels in the umbilical cord are counted, because an abnormal number may indicate any type of cardiovascular abnormalities in the infant. So here is the crowning. We see the top of the baby's head. Here you have the expulsion stage. So if it's here not coming out, this is where they'll start suctioning, and they will slit the vulva in this stage as well, or called the episiotomy, sorry. And here is the afterbirth. So this is where they'll start checking the placenta to make sure it's still intact. No pieces are left in, and they'll also count the umbilical cord just to make sure the child will not have any type of abnormalities. So they have to suction very quickly because they don't know what's going on in here inside. So they have to suction very quickly and then continue to pull the child outwards and grip very gently. Alright, so any questions with this, please, you know what to do. Go to Blackboard and post your questions so everybody can see the questions and my response. So do not send me an email. Okay, go on and look at number 4, our final video.